Welcome, everyone, to this very special event. I'm Judy Fortin, Executive Director of Communications at UCLA Health. It is my pleasure to thank you for joining us today for a scientific conversation with Dr. Anthony Fauci, a world leader in infectious diseases and Director of the National Institute of Allergy and Infectious Diseases. He'll be speaking this morning with Dr. Judith Currier, Chief of the Division of Infectious Diseases at the David Geffen School of Medicine at UCLA. Their conversation will include questions that were pre-submitted by our scientist and physician scientist at the David Geffen School of Medicine at UCLA who are focused on COVID-19 research. But first, I'll turn things over to Dr. John Mazziotta, Vice Chancellor of UCLA Health Sciences and CEO of UCLA Health. Good morning, Dr. Mazziotta.
Good morning, and thank you, Judy. A special thanks to you, Dr. Fauci, for taking the time to spend part of your day speaking with Dr. Currier and, of course, all of us. We know how incredibly busy and in demand you are, so we really appreciate it. We really respect your knowledge, your insight, your experience, and I wanted to personally congratulate you on receiving the National Academy of Medicine's Presidential Citation for Exemplary Leadership last month. This has been an extraordinary time for hospital and healthcare systems around the world, which makes today's scientific conversation especially timely. We've been challenged in ways we never could have imagined, despite training for almost any eventuality. And for medicine and biomedical science, this is our moment. The country, the world, they all look to us for solutions, and we simply can't fail. The University of California, with its 6 medical campuses and a federated database containing data for over 16 million patients, is fully committed to contribute to any and all efforts to understand, control, and prevent COVID-19 infections. Here at UCLA, we focus the depth and breadth of the scientific expertise of the faculty of the David Geffen School of Medicine on this challenge. A good example is the rapid PCR diagnostic test known as SwabSeq. It was developed by 4 faculty members, and it's an approach where individual COVID samples can be barcoded with unique cDNAs and then combined in a single PCR run and separated into individual results by sequencing the cDNA. Thousands of samples can be processed in a single run, taking 12 to 20 hours at a low cost approaching $10 a test. It was recently received emergency use authorization from the FDA. So international team science and collaboration will lead us out of the pandemic. On behalf of our UCLA Health leadership, including Ms. Janice Spiso, President of UCLA Health and CEO of the hospital system, and Dr. Kelsey Martin, Dean of the David Geffen School of Medicine, we are grateful to you, Dr. Fauci, for continuing the scientific conversation and the opportunity to learn and share knowledge. We extend to you our warmest welcome, warm but afebrile.
Thank you.
Now I'm my pleasure to introduce Dr. Judith Currier, Division Chief of Infectious Disease at the David Geffen School of Medicine, where she's a professor of medicine and director of the UCLA Clinical AIDS Research and Education Center. Dr. Currier's work is focused on the treatment of HIV infections, including antiretroviral therapy and understanding the pathogenesis and management of long-term complications of HIV. Since last April, Dr. Currier has served as a member of the NIH Accelerating COVID-19 Therapeutic Interventions and Vaccines Working Group and in a leadership role for the ACTIV-2 treatment trial. Dr. Currier, thank you and welcome.
Thank you very much, Dr. Mazziotta. I'm really pleased to be here today with my colleague, Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases. As many of you know, Dr. Fauci served as the director for more than 30 years and oversees an extensive portfolio of basic and applied research to prevent, diagnose, and treat established infectious diseases such as HIV and AIDS, respiratory infections, diarrheal diseases, TB and malaria, and clearly emerging infectious diseases such as Ebola, Zika, and coronavirus. NIAID also supports research on transplantation and immune-related illnesses, including autoimmune diseases, asthma, and allergies. Dr. Fauci in his tenure has served and advised 6 presidents on HIV and AIDS and other public health crises. He was the architect of the President's Emergency Plan for AIDS Relief, PEPFAR, a program that saved millions of lives throughout the developing world. and has received, as you heard, many prestigious awards. In recent months, he's really become, to many of us, the voice of reason in the scientific approach to dealing with the SARS pandemic in his role in the White House Coronavirus Task Force. I've had the honor and privilege of working with Dr. Fauci in my role in the AIDS clinical trials group since the early 2000s, and his vision to build a global network of sites to address the challenges of HIV treatment and prevention is now being leveraged to combat COVID-19. Throughout his career, he's always ensured that sound scientific evidence guides policy and has unwavering commitment to public health. Before we begin our conversation today, though, Dr. Fauci, we have a special message first to share with you.
Hello, Dr. Fauci. Kareem Abdul-Jabbar here. My friends at UCLA Health are honored to have time with you and learn from your infinite wisdom. You have led us all through this pandemic by telling us how we can do our part in helping to prevent the spread of COVID-19 by reinforcing mask wearing and other healthy behaviors, and by letting us know what to expect. We know we have some challenging months ahead, but with Dr. Fauci as our team captain, I'm confident we'll get through this together. From one basketball player to another, thank you, Dr. Fauci, for your consistent and careful guidance and science-based recommendations. You're helping make America stronger.
And in recognition of your leadership role in team science, we have a special official UCLA jersey for you with number 4 on it and your name that has been sent to your office at NIH. We hope you'll wear it with pride. And Kareem Abdul-Jabbar is going to throw us off with the first question today, and then we'll move into our conversation. Kareem.
Thank you. Dr. Fauci, given the national mood of distrust with regard to science and vaccines, what is the straightest path toward convincing the American public to embrace the necessary remedies that will overcome the pandemic? And more importantly, will that path be straighter than the ball you threw out at the Nationals opening day?
You know, Kareem, they're never going to let me forget that. I got to tell you, regardless of what athletic pursuits I've ever done in my basketball career in high school, this is the dominating athletic event that will follow me, was my errant pitch. But thank you for your introduction to me before. So, Kareem, yeah, thank you. So, Kareem, I think it's important. You asked a really important question. What we have to do, and I've tried to do this over the last 10 months with this outbreak, is to just look at the data and the evidence and the facts, is that when we do the things, the simple public health measures that are directed at preventing the acquisition and the transmission of virus, it works. And those are simple things: uniform wearing of masks, maintaining physical distance, avoiding congregate settings and crowds, trying to do things much more outdoors as opposed to indoors, and washing your hands. They work. I mean, data tells us it works. When we've done that, it works. When we've not done that, we've had the kinds of surges that we're seeing right now. Unfortunately, yesterday was the worst day of cases we've had from the beginning. There were 100,000 new cases yesterday. As we go into it, it affects Los Angeles a little bit less than other regions of the country, but many regions of the country in the coming months are going to get into cooler and cooler, and ultimately the cold weather of the winter, which will force many activities to be indoors. We need to realize that that is a precarious situation. So we need to take a very positive outlook of what we can do to prevent the surges. We're not helpless in this regard. And one of the things we've got to guard against is this fatigue that we all have about the restrictions that we put on ourselves, which are necessary. So we've got to all hang in there together and do those things. And hopefully a vaccine, which I'm sure we'll talk about in a little bit, will be a very important factor in getting us through this. And I believe we will be successful.
Thank you very much.
Right.
Thank you so much for joining us today, Kareem.
It's been a pleasure.
Thank you, Kareem. I appreciate you being here.
No problem. Glad to take part.
All right, so we'll move into the questions. So these questions, some were submitted by UCLA faculty, and I've tried to kind of divide them into topics, but we may wander about. And I did sort of want to start out with your sense of where we are with the pandemic. 100,000 cases yesterday. What you see really as our greatest challenge right now, and if anything, what makes you optimistic?
Judy, what makes me optimistic is I have an inherent faith in the American public and people of realizing that the data are telling us the situation is serious. We have been in serious challenges in the history of our country before. I mean, you don't need me to tell you that there are very important events in our history. We've been through a Great Depression. We've been through a world war, at least in our lifetime. I was born, believe it or not, the beginning of World War II. Tells you how old I am, but it's the truth. We've been through 9/11. We've been through pandemics. We can get through this. We've got to take a positive attitude that if we do the fundamental things that I just mentioned a moment ago, together with, I believe, is going to be good news with regard to a vaccine. We have 6 candidates that we are supporting in the United States. There's 11 candidates globally that are being tested that are in advanced trial. 5 out of the 6 that we're supporting, one way or the other, is in phase 3 trial. 2 of them went into trial on July 27th, and they're fully enrolled. And we should get an answer by the end of this month, the beginning of December, whether we have a safe and effective vaccine. I've mentioned this publicly, and I'll say it here for this forum, that I feel cautiously optimistic that we will have a safe and effective vaccine, more than one. We likely will have more candidates than one. We have multiple different platforms. And when we do, we will then begin deploying vaccines. And I think that's coming soon. We should know by the end of December, middle of December, and start deploying vaccine by the end of the year and the beginning of 2021. That's still not firm because you never can tell with vaccines. They sometimes surprise you. But I think that we're going to be there. And I think that's the thing, combined with the continuation of some element of public health measures. I believe we're going to get out of this. We will beat this. We should not feel helpless and discouraged. We're going to get out of this, I promise you.
Okay, great, thank you. And so starting with testing data, we've expanded our approach to testing. Where do you think we're going with the possibility of home-based testing? Do you think that will become a reality, and where do you see that fitting in?
Judy, I think not only become a reality, I think it's got to be a necessity beyond a reality. I really think we need to have a situation very similar to pregnancy tests, where individuals literally can know in real time, in a very inexpensive way, on their own, whether they're positive or not. I mean, you want to get a big database so that we understand. We all appreciate that. But if you look at the kinds of things that we're facing now as we enter into the holiday season, wouldn't it be nice to know that if you wanted to get your family together, that you could have readily available to you, just as inexpensive as a pregnancy test? You get 7, 8, 9, 10 members of the family. You test them. If you're negative, enjoy the Thanksgiving holiday. If you're positive, make sure the person that's positive is taken care of in an appropriate way that's quarantined. To me, we've got to get to that goal. That's a very important goal.
Thank you. So let's move into vaccines. You put a big emphasis on the really critical progress that's been going on with vaccines. And we've been fortunate here at UCLA. Dr. Jesse Clark is using the infrastructure from the HIV Prevention Trials Network community site, enrolled the Moderna vaccine trial. And Rafi Landovitz has just opened the AstraZeneca trial with support of our CTRC. So we're very much involved in rolling out these studies and getting them enrolled. One of the questions that people are asking as they come into the study is what happens if there's an EUA with another vaccine? What do you think we should do with respect to how should we approach this in these trials, and trying to retain the integrity of the trial, but also understanding the participants, really eagerness to have a vaccine?
Yeah. Well, there are a couple of, that's a question that gets asked multiple times a day, every day, Judy. I mean, because it's a really, really good question, as you well know. And what we actually are discussing now with a group of ethicists and have been for some time, there are a couple of factors that are going to play on what happens if you have, as you said, we have the 5 candidates in play now. So let's say candidate number 1 gets an efficacy signal that allows for the company to apply to the FDA for an EUA, an emergency use authorization. What happens, A, to the placebo group in that trial, but as importantly, what happens to the other 2, 3, and 4 trials? And the answer is it depends on 2 factors, Judy. One is how effective the vaccine is. I mean, if you're dealing with a 98% effective vaccine, God help us, I hope we get there. I'm not so sure we will. But if we do get one that's extremely effective, then you've got to take a look at the ethical consideration of not making that available widely. However, the second factor is as important, because I can tell you, based on the pace that doses are going to be available gradually as we go from December, January, February, March, it is very likely that you're not going to have enough vaccine to widely distribute, which means there's an ethical reason to keep the other trials going so that you do, and we've discussed this in great detail, even though you have something that has a signal of efficacy, if A, the efficacy is 55, 60% and not 98%, and B, there's not enough vaccine around anyway to give it to everybody, then you have a societal responsibility to continue the trials as they are. That's what we want to do. Now, under the circumstance of a particular situation when maybe a few months down the pike, you have a lot of doses available for people. Then if you have a very effective vaccine, you may want to make the placebo limb of the other vaccines the vaccine that has been proven to be effective, and do what we're all familiar with is a non-inferiority trial to see if you could show they're either equivalent or non-inferior. So there are a couple of ways we can do that without disturbing the scientific process of getting a good answer.
That's great. And I think that really speaks to the coordination between these studies and the oversight being under one big umbrella to make that possible.
Well, that was the reason, Judy, why we, when we did this so-called harmonization, we have a common data and safety monitoring board. We have common primary and secondary endpoints, and we have common immunological parameters that could be used for correlates of immunity. I think that's going to help in what I was just talking about.
And as we do get more information about vaccines, one issue is people who've received one vaccine in a study, and then maybe another vaccine becomes available. Is there any concern about being vaccinated by 2 different vaccines over time, boosting the immune response potentially?
Yeah, well, you need to look at it in 2 phases. If you get a prime boost, you want to get the boost for the same vaccine that you were primed for. So what you don't want is a prime from Moderna and a boost from Pfizer, or a prime from Moderna and a boost from Janssen. You want to keep that. But if you get a prime and a boost, and you get a vaccine that's like 50% effective, 60%, 65%, and then a vaccine comes out that's 88 to 90% effective, we'll do the same thing as we did with the Zoster vaccines. Remember, the first one came out, it wasn't as good as the second one, and we were encouraged to get the second one, even if you got the first one. I think that's the way it's going to be, Judy.
That's really helpful. And do you think, given that we don't really understand how durable the immune response is, in people who recovered from COVID, from severe COVID, should they be vaccinated?
Yes. That's an easy answer.
Okay, good.
No, the reason is that historically, coronaviruses, as you know, with our experience with the common cold coronaviruses, and even with our experience with SARS-CoV-1, that you're not dealing with a durability of immunity along the lines of measles, which is like lifetime. So there's a finite nature to it. So since we don't know exactly the bounds, the outer bounds of what protection is, I think the better part of valor would be to get vaccinated, even if you were. As a matter of fact, built into the trials, Judy, that we're doing, if someone comes in and gets screened and has antibody, they're still part of the vaccine trial. They don't get disqualified.
And do you think that these kinds of vaccines are going to be needed to be given annually, or at what interval are we thinking right now?
I don't have an answer to that, Judy, and that's going to depend on when we look at 6 months, a year down the pike in the follow-up, how long the durability of the antibody lasts. And it is conceivable, you know, I hope we don't have to go through that, but it is conceivable you may need to get boosted every 1 or 2 years. That's quite possible.
Yeah. May St. John, who's our chair of the Department of Head and Neck Surgery, would ask really what your thoughts are about it. Once we have this vaccine and we're able to roll it out, how long will it take for things to get back to normal? Just give people the expectation of the time.
Well, another extraordinarily commonly asked question, because it's on everybody's mind. And if you look at the practicality of getting people vaccinated, it likely will be that there are going to be some vaccine hesitancy, Judy, that we all are unfortunately familiar with. So there's going to be groups of people who would not want to get vaccinated or would like to wait to see, after multiple millions of people got vaccinated, that it really is safe, which we wouldn't have approved it if it wasn't anyway, and that it is really having an impact on infection. So you could expect that probably by the third quarter of 2021, you're going to get most of the people that you want vaccinated. You are not going to be able to completely dismiss public health measures. So I see it as a gradual approaching what we consider increasing normality. For example, you may, with the vaccine and public health measures like wearing a mask, be able to gradually, over the months of 2021, instead of saying theaters can't open, you could have theaters that would be open with a limited capacity. Sporting events in which you had no spectators now would likely be able to have spectators with a limited capacity. Restaurants that you don't open at full capacity likely will do that. I see it as sort of a gradual progression into that. I don't see it like a light switch turning on and off. You know, no public health measures or all public health measures. You're going to have a gradual diminution so that within a period of multiple months, within 2021, we'll start approaching normal. I would imagine by the end of 2021, we should be almost there with a good vaccine.
Okay, great. I want to turn to therapeutics. You know, I have to ask about therapeutics, and early treatment, you know, had not been a big focus early on. And we've really been here at UCLA, and personally been really interested in this issue of, could we be treating people earlier? What are your thoughts about the importance of early treatment and identifying those people who will benefit from it, where its role in the pandemic?
I think it's the dominating issue right now in therapeutics, Judy. We have to do that. As you know, we have 2 randomized placebo-controlled trials, one with remdesivir, one with dexamethasone, hospitalized individuals either on ventilators or requiring high flow oxygen. These drugs are good. Dexamethasone, much more, you know, robust in the sense of preventing diminishing 28-day mortality. We have multiple candidates for early disease, but they're all in testing without necessarily having been approved yet. I mean, we have convalescent plasma, which has an EUA, but we really want to look at what the actual clinical trial data show. We have hyperimmune globulin. We have monoclonal antibodies. What I would really like to see, something I know near and dear to your heart, is what we did with HIV, where we looked at the replication cycle of the virus and we were able to identify multiple vulnerable spots in the replication cycle and tailor a targeted antiviral drug for that. If we could do that, what I would foresee is that when someone comes in with symptoms, they may even be mild symptoms, immediately give them a limited course of 1 or 2 or more antivirals to block replication early on. We know from the most recent monoclonal antibody trial that if you do it in hospitalized patients, the results are not what you would like to see because you're getting them a little bit too late in the course. You want to hit them really early. The best way, in my mind, to do that is an oral preparation, kind of a Z-pack for COVID-19. You go, you take it for 5 days. You probably won't have to take it for any more than a few days because of the dynamics of the virus replication that we know from natural infection. I think that's an attainable goal, and I would love to see us get there pretty rapidly.
Yeah, thank you. I know a lot of people are working really hard on that, and getting people to participate in studies of early treatment as outpatients has been challenging because they're told to stay home and wait and see if they get sick. But I think with more promising treatments and early results, that the tide will change there.
Right.
Speaking of the variable clinical presentation, this has been a remarkable issue with COVID-19, how people's clinical course varies. What are your thoughts on what underlies this? Is it the host? Is it the virus? What's going on?
You know, it's probably about 5 separate things. This has completely baffled me, Judy. I often say when people ask that question one way or another, I've never, ever seen anything like this. In all of the viral and other pathogens that I've been following and fighting over the last 40 years, I've never seen anything even approach this, where you get 40 to 50% of the people who are infected have no symptoms at all. Of the people who get symptoms, 80% of them have mild to moderate symptoms that don't even require any medical intervention like hospitalization. Then you have 15 to 20% of the people who have severe or critical disease that goes on in people with underlying conditions and aged to have a mortality that ranges from a few percent to as high as 20% on people who require mechanical ventilation. That's unheard of, to have that degree of a virus that can kill you, the same virus that in 40% of the people that has no symptoms at all. So in answer to your question, why is that? I think it's a number of things. I think it's inoculum, a virus that you get, number one. It's clearly immune capability. That's why younger people really do fine for the most part, with some notable exceptions. There's got to be genetic polymorphism in there for sure. We already know a certain percentage of people make autoantibodies against interferon or who lack expression of interferon. So I just think there's so many different things that they're probably a combination of 4 or 5 that we don't even recognize yet. But it is so noteworthy. You know, every infection, Judy, that you and I have dealt with have never even come close to that. I mean, you get infected with HIV, subtract the elite controllers who are less than 1%. If you don't treat people, sooner or later, everybody is going to get into trouble with HIV, sooner or later. That's not the case here. Some people die a very, virulent type of a process that kills them, and some people get no symptoms at all. They're so unique among viruses.
Do you think there's any evidence that the virus is changing over the course of the pandemic, that we need to be concerned of it evolving and changing its virulence?
Well, as an RNA virus, it's certainly mutating, as all RNA viruses do. The only mutation that suggests not virulence, but more transmissibility is the 614 mutation of a D to a G, which just essentially in vitro, at least, makes it bind to receptors better. So you can make an extrapolation that maybe it's easily transmissible, but nothing indicating that it's more virulent. In fact, there's some suggestion, purely anecdotal, that it might be less severe. We don't know. Maybe that's because younger people are getting infected now. I'm not sure. But we don't see any evidence that it's becoming more virulent.
Okay, and another aspect of the clinical presentation is the post-acute COVID syndromes that are being described now, this post-viral syndrome. What do you think is different about this coronavirus that might be driving this? And are these similar to other post-viral syndromes? And I guess my big question is, will early treatment prevent this?
The answer is we don't know whether early treatment is going to prevent it. It certainly exists, this post-COVID-19 syndrome of prolonged recovery and persistence of rather common symptoms that vary from weeks to months following virological clearance. And it's very reminiscent in some respects to myalgic encephalitis, chronic fatigue syndrome. It's got some differences there, but clearly some similarities. People have profound fatigue, shortness of breath, dysautonomia, temperature control, some fevers, headaches, sleep disturbances, and what they refer to as brain fog, or an inability to concentrate or to focus. We have a study here at the NIH of a few hundred people we're following. And, anywhere from 25 to 30% of them have these persistent symptoms. And they are really rather consistent in what they are, that kind of prolonged fatigue. We've seen that post-EBV with certain individuals with mono. We've seen it post-influenza with a very small percentage of people who take a while to get back their full energy from influenza, but nothing as profound as this. So it's going to be studied intensively, Judy. There's a whole bunch of proposals that are actually on my desk right now that I have to look at, that are trying to get some additional resources for different places, including UCLA and other major centers, to be looking at this.
One question from Dr. Brian Such from urology was about whether this inflammation related to COVID, some viruses can cause cancer or associated with cancers subsequently. Do we need to be worried about there being secondary cancers down the road with after coronavirus?
I mean, obviously, you always worry about that when you're dealing with a new virus. I don't see any reason, even the people who have the chronic symptomatology that we're following, and again, it's a relatively small study. It's measured in hundreds, not thousands yet, that the classical markers of aberrant immune activation are not up, Judy. D-dimers are not up. Other, CRPs and SAD rates are not up. The people just feel completely wiped out without indication that there's a smoldering level of inflammation going on.
In our last few minutes, I want to turn to the research enterprise. COVID initially shut down a lot of labs and stalled research in many areas, and this is starting to improve. But I worry a lot about the impact on young scientists, and particularly those who have young children at home and are dealing with being now homeschooling their children and trying to keep their labs going. What advice do you have for young investigators at this point?
Yeah, the advice is simple. Hang in there. This is going to end. We're going to get back to normal. I know I do spend some time, Judy, with people who call me, write me, and text me asking the same question. Give me advice. What do you think? They're getting discouraged. Don't get discouraged. This is going to end. We are going to get back to normal, and we're going to do. And hopefully, we've asked the Congress for a significant amount of money to do catch up, to get the system afloat again, because we've had to put a lot of things on hold. And as you well know from your own experience, the people who get hit the most are women scientists, because they have family obligations. When kids don't come home, when kids don't go to school, it's the women scientists who have to worry about, what am I going to do with my child? So we've really got to correct that.
The other thing that I get asked about a lot are people have gotten involved in COVID research who are doing other types of things. And now they're kind of at a crossroads of trying to decide how much effort and time should they continue down the COVID pathway or what they were working on before. You've had these crossroads in your career in the past. What advice do you have for that
You know,
decision.
what I would do is follow the scientific opportunity, Judy, because you may be onto something in your work on COVID that is really hot. You know, when things calm down a bit, you may want to say, you know, this is worth pursuing. Maybe I can come to an answer on this. I have to tell you, quite frankly, an interesting question. I have at least 2 people in my own laboratory who were pure HIV people for decades, who are now switched over and looking at the same sort of things about receptor binding and things that they've worked with HIV, who are very excited about what they're doing. So I'm not going to tell them to go back to HIV or to do what they're doing. Just follow the excitement of the science and where it takes you.
I think that's great advice. You know, we have seen this pandemic just having such disproportionate impact on minority populations. And in the research enterprise, I think it's shed a light on our need to have a more diverse workforce of physician scientists and researchers. Has this been something you've been thinking about, what we can do, what NIH can do to really help grow the pool and developing a more diverse workforce?
We are full-blown committed to this right now, right from the very top. I give a lot of credit, Judy, to Francis Collins, the director of NIH. All of the institute directors are interested in really getting a more diverse workforce at the highest levels as well as intermediate levels and lower, not just the lower levels, but the highest levels. We have a major commitment to that. In fact, I'm just starting in my own office here at NIAID, an officer of workforce diversity. So we are taking this very seriously.
That's terrific. I know you only have a couple minutes left, and just wanted to ask if there was anything that I didn't ask you about that you'd like to talk about today, or that you'd like to share your opinion with our group of research scientists here.
Well, you know, Judy, you were very complete in your questioning, and they were all really important, relevant questions that are being asked throughout the country. You know, the thing I want to emphasize to the students and the fellows and the postdocs who are working on fundamental basic science questions is that we would not have gotten off the ground as quickly as we did with things like vaccines and therapeutics if we hadn't relied on the decades of fundamental basic science work that you've done. So when basic scientists are sometimes feel or being told that what their work doesn't have much practical consequence, well, the people who were working on vaccine platforms, the mRNAs and the vectors and all of the things that were done on a very fundamental standpoint are right now right at the forefront of practicality. So it's just another proof of the importance of the marriage between fundamental basic research and the kind of things that you and I do when we get out and take care of patients and do clinical trials. They're very closely linked.
Well, I want to thank you so much for taking your time today to spend some time with us, and for your continued leadership. Really, I just can't tell you how much people appreciate your leadership during these really difficult times. And I'm going to throw it back to Judy Fortin to close out the program.
Yeah, thank you, Judy.
Thank you, Dr. Fauci, and thank you so much, Dr. Currier. We've now come to the end of our session, and we're so glad that UCLA Health could offer this very special program today. We appreciate everyone's time. David Geffen School of Medicine at UCLA is so fortunate to have leadership from Dr. Currier, Dr. Mazziotta, Dr. Fauci. Your time today is greatly appreciated. And we'd like to thank all of our community members who joined us today, many of whom are our own devoted faculty members, researchers, staff, and committed philanthropists who all contribute in exceptional ways to progress in science and medicine. We're grateful for the strength of our UCLA community, and we look forward to seeing all of you soon. Thank you again, and have a wonderful day. Bye, everyone.
Bye-bye.
Right. Thanks a lot, folks.
Thank you.